Hi everyone, and we will discuss in this video the further pharmacodynamics. Now, we understand how the drug works. The drug works by non-receptor and receptor mediated action. So in this video, I'll be discussing what are the meaning of agonist, partial agonist, antagonist, as well as inverse agonist. And we'll also discuss the graph here, the dose response curve graph, and what are the important things you need to remember here. So let us start our journey. We all know that how the drug works. Drug, this is the drug. It binds to the receptor. The drug binds to the receptor. After binding to the receptor, what you see is a response. So the drug binds to the receptor and what we see is response. I will give a classical example. Adrenaline is a drug. Adrenaline acts on the receptor called beta 1, and beta 1 is present in the heart, and what you see is increase in heart rate. So increase in heart rate is what we mean by the response. Now, how do I know a drug is an agonist or an antagonist? Let me tell you, when the drug binds, it should bind on the receptor, and when it binds on the receptor, it should produce some response. Now, the drug can be agonist. How do I know that? For that, you need to understand a concept called affinity. So what do you mean by affinity? Affinity is nothing but ability to bind receptor. So ability to bind receptor is what we mean by affinity. So when we give the drug should bind to the receptor. Now once it binds to the receptor, it should not sit quiet. It should produce some response. So that response is also called as intrinsic activity. So that response is also called as intrinsic activity. So you learn two terms, affinity and intrinsic activity. Simply remember, affinity means ability to bind to the receptor. Intrinsic activity means producing a response. Now, can you tell me, is albumin a receptor? No. Even the drug binds to the albumin, but it will not produce any response. So, plasma proteins are not receptors. Now, what is an agonist then? What do you mean by an agonist then? Now, agonist has affinity, but it produces an intrinsic activity +1. The meaning of +1 is it produces the maximum response. So the meaning of +1 is you will see the intrinsic activity which is maximum. You will see the maximum response. Then we have another term, and that is called partial agonist. Now, partial agonists also bind to the receptor. They have affinity, but their response is between 0 to 1, not 100%, not +1, not maximum, sub-maximal, not 0, not 1, in between that. Okay, so the response is between 0 and 1, or between 0 and maximum. That is called partial agonist. Then moving on to the next one, antagonist. So antagonist also has affinity for the receptor, but it produces the response 0, no response. So antagonist is also called by another name. They are also called as blockers. Suppose if I tell alpha blocker, the meaning is I am telling you they are alpha antagonist. Then we have another concept called inverse agonist. Now inverse agonist also have the affinity, but their response is -1. Sir, what do you mean by -1? Will it not produce a response, or will the response be decreased? No. The meaning of -1 is what you see is opposite response. The meaning of -1 is opposite response. So please remember these things. All of them have affinity. They have to bind to the receptor. After binding to the receptor, depending on what response do they produce, they are classified like this. Now I'll take an example. Let us imagine that you are sitting in the live class. You are all listening to the class. And when you are sitting in the class, you have to sit on the chair. The chair is the receptor. So you all sit in the chair because you have affinity. But how do I decide you are agonist to the class, antagonist to the class, or a partial agonist? Now you sit in the chair and listen to the full class, maximum, then you are agonist. You sit in the class, in between you sleep, in between you get up and listen to the class, you are a partial agonist. You sit in the class, from morning to evening you will be sleeping, and you are blocking a chair for someone. So you are a blocker and an antagonist. What is inverse agonist? Can you imagine? Opposite action. That means instead of me, you take the class. So that is called opposite action, that is inverse agonist. Now if I plot this in a graph, how does it look like? How does it look like? Let me draw that. So this is the line, and we see +1, and this is -1, right? And in between we have the response, that is 0. Now let me draw a graph. What happens when we use a agonist? When I use an agonist, you will get the full response. So this graph is for the agonist. Now if I give a partial agonist, the graph is like this. So you will not get the full response. The response is between 0 to 1. So this is called the partial agonist. Now if you trace the 0 graph, it is the antagonist. This one is the antagonist. And now if I trace it below down, -1, this is what we mean by inverse agonist. This is what we mean by inverse agonist. This is the graph. So this can be asked in your exams. Identify this. Classical example I will give you: agonist drug. For example, the examples are a classical drug called benzodiazepines and Z drugs. And the antagonist for these receptors, particularly the GABA, is a drug called flumazenil. And the inverse agonist for this is beta carbolin. This is an example for you. Now remember, if there is usage of benzodiazepine, benzodiazepines are nothing but sleeping tablets. So when we give benzodiazepine, the patient will sleep. Very good. Suppose the same person has benzodiazepine poisoning, we can give an antagonist, and that is called flumazenil. Now you tell me guys, if I give beta carbolin to a person, will he sleep or will he become excited? Obviously he will become excited. So that is the meaning of inverse agonist. So here we understood what is the meaning of agonist, partial agonist, antagonist, and inverse agonist. Depending on that, in the future systemic pharmacology, I will tell you this drug is agonist, this drug is a partial agonist, this is an antagonist or blocker. Or I will be telling you inverse agonist. That is the meaning of this. So once you understand agonist, partial agonist, then antagonist and inverse agonist, let us understand one more concept, and that is called the dose response curve. Let us understand a concept called dose response curve. What do you mean by that? I'll take the example of a drug called adrenaline. When I give adrenaline, it acts on beta 1 and there is increase in heart rate. Now what happens if I increase the dose of adrenaline? The response also increases. Now if I plot the same thing in the graph, that is called dose response curve. If I plot that, that is called dose response curve. I'll ask you a question. If I increase the dose of adrenaline more and more, will the heart rate become 100? Yes. 200? Yes. Will it become 300, 400, 1000, 2000? No. There is a point where the response becomes maximum. After that, whatever dose you increase, it will not go above that. So that is called the maximal response. So let me plot that graph and show it to you. This is the y-axis. Any graph, try to understand what is y-axis and what is x-axis. And this is the x-axis. Now, whenever you see that, please understand what is there in y-axis. In the y-axis, what we represent is the response. For example, increase in heart rate. Now, in the x-axis, what we see is the dose of the drug. You know that when I increase the dose of the drug, response also will increase. So, when we use more and more, what happens to the response? The response keeps on increasing and increasing. After some time, the response will not increase. So, you have achieved the maximum, and that is called 100% response. After that, whatever dose you increase, the response will not increase because the receptors are limited. So this is what we mean by the dose response curve. Now, what are the drawback of this? The drawback of this, for example, this represents adrenaline action. I want to compare one more drug with this. Suppose I want to compare noradrenaline action. What happens? I'll take a different color. Both the graph will overlap. So noradrenaline graph and adrenaline graph overlap, and I cannot compare them. Who is better? Next one, you cannot compare large doses. For example, the dose is 1 milligram here. Here it is 2 milligram, 3 milligram, 4 milligram or 5 milligram like this. You cannot compare 1 milligram and 10,000 milligram. So that much higher doses cannot be compared with this graph. For that, you require so much bigger access. For example, 1 milligram of adrenaline, I want to compare 10,000 milligram of adrenaline. Not possible. So I'm just hypothetically, I'm telling you that. So then the scientist thought, we'll do something else. Then they came with one more concept, and that is called log dose response curve. Log dose response curve. They came with this concept. What did that change? The change is here. So this is the y-axis and this is the x-axis. So what is the change they did? They just changed one thing. What is that? Instead of plotting the x-axis in the normal numericals, they made it logarithmic scale. So suppose the dose is 0.01 here. This is 1. This is 10. This is 100. And this is 1000. So let us understand its milligram like that. Now here the advantage is you can see here 0.01 to 1000 you can compare it easily. So this is called logarithmic scale and we call it as log dose. So the dose is represented in logarithmic scale. Now the response is same in the y-axis. The response is same represented in y-axis. And the maximum response, what we mean is 100%. This is what we see. Now when we plot the graph, you get a graph and the graph looks like this. So the graph looks S-shaped. And what is that S-shape called? The shape of the curve is called sigmoid shape. So the curve is sigmoid curve. Now why after this it will not go up further? Because it has reached the maximum level. So it is a S-shaped sigmoid curve. And the maximum response is 100%. And there is one more response that is 50% of the response. Now when I understand this graph, I need to understand two important things. Now response is also called by another name that is called efficacy. What is the other name for response? It is also called as efficacy. That means more the graph goes above y-axis more and more, the response increases. So what we call it as efficacy increases. Now coming to the dose. Now let me take an example. There are two teams, A team and B team. A team requires only 2 people to lift a table. We require only 2 people. B team require 4 people to do the same job. Now tell me, which team is more potent? Pause the video and tell me. Obviously, we are all telling A team is more potent because you require less number. And B team is less potent because they require more number. Similarly, if you require more dose, you are less potent. So can I write dose of the drug is inversely proportional to potency? Dose of the drug is inversely proportional to potency. More the dose, less is the potency. Yes. So whenever we talk about dose, remember we are talking about potency, but they are inversely proportional. Lower the dose, more is the potency. Please keep that in your mind. So we understood two important aspects, that is the dose and response. The dose is correlated with potency and response is correlated with efficacy. Now the middle part is what we mean by the slope of the curve, and we will discuss that later. What is the importance of slope of the curve? So three things: efficacy, potency, and slope of the curve. What is more important? Now what happens is there is a 50% response you see. So this is called ED50. What do you mean by ED50? The full form of ED50 is effective dose 50. So let me tell you again, effective dose 50 is nothing but what is the dose required to produce 50% of response. I'll repeat again, ED50 is the dose required to produce 50% of response. So here in this example, to produce 50% of response, how much you require? 10 milligram. So let me write it as milligram here. So the ED50 is 10 milligram here. They can ask in the exam, ED50 is a measure of. I'll give two important aspects for you. Is it a measure of efficacy or is it a measure of potency? So take your time and answer this. ED50 is a measure of what? Most of you are trying to answer efficacy. No. Now I told you it's the dose. Whenever the dose comes, I am talking about potency. Remember, ED50 is a measure of potency because I am talking about dose. How much dose is required? So whenever I talk, ED50 is a measure of potency. Sometimes this ED50 is also called as EC50. EC stands for effective concentration of the drug, that's it. Either they can give you ED50 dose or they can give drug concentration, that is EC, that is called effective concentration. So what is the effective concentration of the drug to produce 50% of response? So we understand this graph, very much important. Log dose response curve. Log dose response curve. Now, why should I understand the slope of the curve? Why should I understand this? Let me give an example for that. So this is the y-axis, this is the x-axis, and we know that is the response, and this is the dose of the drug. Now, there are two drugs. Let me write two drugs here. One drug is producing a response like this, and one more drug is producing a response like this. Now let me tell it as A and let me tell it as B. So this is the response, this is the dose. Now tell me, if I want to prescribe a drug to a person, will you prefer giving A or B? Which one is better? Which one is safe to use? A or B? Take your time. Now remember, this middle part is the slope of the curve and this is very steep here. So this is called the steep dose response curve. What happens if the dose is too much steep? For example, if I give a bit of dose higher, patient will get huge response. Suddenly the heart rate may increase more. But if the slope is flat, even though if I increase the dose so much, the response is not so huge. So which one is safe? Flat DRC, this is safer, and steep DRC are less safe. The classical example is barbiturates. So barbiturates are called as sedative hypnotics, the sleeping tablets. Until now, you remember like this. Now, certainly patient increases one extra tablet, patient may end up with respiratory depression, coma, death. But benzodiazepine, the B here is benzodiazepines, they are safer because even if you increase the dose much, the response is not so steep. So steep means lesser safer, flat means more safe. So this is what we get from the slope of the curve. So guys, we understood what is the dose response curve, what is the importance of efficacy, potency, and we understood slope. Now one more thing I want to ask you, when we prescribe a drug, are we worried about efficacy or are we worried about potency? Yes, what is important for us? What we are worried about is the efficacy. We don't worry about how much dose we are using. For example, let me take a drug for diabetes. For diabetes treatment, we use metformin, 500 milligram. And we use another group of drug that is called glimepiride. So 1 milligram. Now both of them will decrease the HbA1c by 1 to 2%. They decrease the HbA1c, that is called glycated hemoglobin. They both have the ability to decrease 1 to 2%. So this is their response efficacy. Now, should I tell the dose is more important? Accordingly, if dose is more important, 500 mg is too much and 1 milligram is very less. So we are not worried about the dose because most of the patient come to the clinic, sir, you have written so much high doses. The drug will work only with that dose. If I don't give that much dose, the drug will not show efficacy. So dose is not much important. That means potency is not more important. What is more important is the response, that is efficacy is most important. Okay, so let me give an example and you need to answer this. Pause the video and just answer this query for me. Now, I've taken this graph. You can see the response here, dose here, and we have three different drugs, A, B, C. Now, you need to do one thing. You have to arrange them in the order of efficacy, which is most efficacious, then intermediate and least. Then you have to arrange them based on potency. Yes, can you do that? Yeah. Now remember, this is 100% response and this is 50% response. So when we write the efficacy, who is efficacious? Remember, A and B are equally efficacious. That means both are producing the same response. Both are producing the same response, and who is producing the less response is C. So the least efficacious drug is C. So whenever you have to check efficacy in the graph, always check the y-axis. Whoever is tall, they are most efficacious. So A and B are equal height. That means they are equally efficacious. What about potency? You take the potency like this, ED50 for this. You take the ED50 for this. You take the ED50 for this. So lower the dose. This is for A, this is for B, and this is for C. So lesser the dose, more potent. So to produce a 50% response, what drug requires lower dose? That is potency. Who is more? A, more than B, more than C. Or simply remember, if the graph is towards this side, if the graph is moving this side, what happens? The dose is decreasing. The dose is decreasing. What happens if dose is decreasing? Potency is increasing. Yes. So the graph A is towards this side. So the dose is lesser, potency is more. So A is more potent than B than C. Now if the graph moves from here to here, what happens? That means we are increasing the dose. So when we are increasing the dose, potency is decreasing. So this is the application. So simply see this graph, you will understand that. Right? So A, B, C. Now classical example is what we all understand. Let us understand A is nothing but a drug morphine. B is pethidine. And C is a drug called aspirin. Aspirin. Now A patient has come to the clinic with a cancer pain. Now remember, for cancer pain, which is most effective, they are opioids. The opioid drugs in these examples are morphine and pethidine. They have maximum efficacy to decrease the pain. So that's why you written for a cancer pain, A and B, that is morphine and pethidine, have equal efficacy. But whatever you give aspirin, the aspirin will not decrease cancer pain so much. That's why the efficacy of aspirin is very, very less. Sir, what about the dose, potency? Now morphine, if I take the example A as morphine, you can use it at low dose. For example, if I use 1 milligram of morphine, you have to use 10 milligram of pethidine. That means you are using higher dose of pethidine. So higher the dose, less potent. Yes or no? And lower the dose, 1 milligram morphine, it is more potent. Now please tell me, what is most important in our practice? Efficacy is most important or potency is most important? Obviously efficacy. If you increase the aspirin dose too much, even if you increase the aspirin dose to 600, 1000, 2000, the cancer pain is not going to come down. So potency is not going to play a major role when we prescribe the drug. What is most important is how the drug responds. Response is most important, that is efficacy. So guys, in clinical practice, if they ask the exam what is most important is efficacy of the drug and less important is potency. Another important aspect I just want to tell you is what is the difference between efficacy and effectiveness. What is the meaning of efficacy and effectiveness? Now, efficacy is done in ideal conditions. Ideal condition. For example, we do clinical trials. In clinical trials, we take the patient, we have some inclusion criteria, exclusion criteria. We take only certain population, not everyone. For example, in clinical trial, when we are testing a drug, we don't take pregnant women, we don't take too much aged people, we don't take children and all. So we take people, and in ideal condition, we see a response. That is efficacy, usually seen in the clinical trial. What is effectiveness? It is seen in a real life situation. So when I give a drug to a patient, for example, I am discovering a drug for diabetes. Patient will not have only diabetes, he may have hypertension, he may have dyslipidemia, he may be taking other drugs also, there may be drug interaction also. Then we see a different response. So that what you see in the real life situation when you start prescribing the drug to the patient in your hospital, in your clinic, and when we tell that, that is called effectiveness. Efficacy is seen in ideal condition. When we do an experiment, we do a trial there. That's the only difference. Effectiveness is what you see when you start prescribing as a doctor and in a real life situation. That is what we mean by effectiveness. That's it. So until now we understood what is agonist, partial agonist, antagonist and inverse agonist. Then we understood what is the dose response curve. We had a curve, hyperbola curve, but the problem is you cannot compare two drugs. You cannot compare log doses. We came with log dose response curve. Response is also called as efficacy, and dose is related to potency inversely, and the slope of the curve, what is important. And when we start prescribing, what is most important is efficacy compared to potency. We understood that. Another important aspect when we talk about the log dose response curve, remember there are two types of curves like this. One is called the graded dose response curve. So it is called the graded dose response curve. Until now what I discussed with you all, that is called graded dose response curve. The meaning is if I increase the dose more and more, the response also increases. Suppose I increase the dose of adrenaline more and more, the heart rate also increases. So it is graded. Quantal, another one is called quantal dose response curve. In quantal dose response curve, remember the efficacy is fixed. Meaning, suppose I am giving adrenaline to a patient, I want to check what dose of the adrenaline increases 10 beats per minute. So I am not checking whether it increases 20, 30, 40. I just want to check how much dose will increase 10 beats per minute in each and every individual. So here, graded dose response curve, we do it in a single patient. So individual, we do it in a single person. So we give adrenaline in the single person and see what is the increase in heart rate. But here, we do it in population. We do it in population and it is called all or none phenomenon. So here we see all or none phenomenon. That means yes or no. When I give adrenaline at this dose, whether there was increase in 10 beats per minute or not, yes or no. When I give adrenaline, whether the patient died or not, yes or no. That is called quantal dose response curve. Now let me write that quantal dose response curve for you here. So this is the y-axis, this is the x-axis. But there, if you remember, that was an individual. But here in the y-axis, what we represent is, it is nothing but percentage of population responding. Percentage of population responding. So let me take it as 100%, this one as 50% population, or you just think that we have taken 100 people and we are giving the drug. You take an example of paracetamol. Now when I give paracetamol, I just want to check whether the fever decrease or not. Yes or no, that's it. Now for few people, if you give 200 milligram of paracetamol, the fever decreases. For few people, if you give 500 milligram, the fever decreases. For few people, if you give 650 mg, fever decreases. And for few people, if you give 1000 milligram, then only the fever decreases. So few people will respond different with different dose. That's why this will help us to understand that variation. So if I write a graph for this, we'll get the same, and this is the log dose. So we get the same graph like this. Let me write the sigmoid curve for you. Yes. So if I check the efficacy, what we get is the efficacy graph. So this is what we mean by the efficacy graph of the drug. Efficacy graph. Now, in 50% of population, what is the response you are getting? That is called ED50. So ED50 in this graph represent 50% of population, what dose will give the response. For example, you know paracetamol, majority of people, if I give 500 to 650 mg, the fever decreases. So that is the ED50. So 50% of the population. For few people, if you give 1000 milligram, then only fever decreases. This point. For few people, if you give 100 milligram, that will show the response. Very rare. 100 milligram an adult, if you give, that much fever reduction will not be seen, but very rare. But majority of the people come under ED50. And because of that only, we decide what is the dose of the drug. Now, if I give paracetamol too high doses, if I give 8 gram of paracetamol, what happens? If I give 8 gram of paracetamol, what happens? I will lead to toxicity. So I will get one more graph, I'll write it here. I will get one more graph. So that is the toxicity graph. So we see the toxicity. The same drug, if I give high dose of paracetamol, I will see toxicity. For few people, low dose may cause toxicity. For few people, very high dose may cause. And majority of people, there is a dose called toxic dose 50. That dose will cause toxicity, particularly paracetamol hepatotoxicity. So this is what we mean by TD50, toxic dose 50, and this is the toxicity graph. So a drug will have efficacy graph and toxicity graph, which is compared in population. So this is called ED50 and this is called toxic dose 50. But if the drug is killing someone, causing death, so we also call it as LD50. LD50 stands for lethal dose. Suppose you are taking the parameter as death. Usually we take lethal dose when we do animal study. So when we give high dose of the drug, animals will die. So with that dose, will the animal die or not? So that is called lethal dosing. Okay, sir, we understood all those things, but why are we studying this? What's the importance of it? The importance of it is to understand a term called therapeutic index. So therapeutic index is given by the toxic dose 50 divided by effective dose 50. So that is the measure of therapeutic index. Okay, sir, we understand. Or it is also written like LD50 divided by ED50. So when you take lethal dose 50 in animal experiment, it is nothing but what is the dose to kill 50% of animals. That's it. Now, why should I know this? Now, let me give an example for you. A drug A, I will give example. This is drug A and another example for drug B. Okay, there are two graphs. Now, this is the efficacy graph and this is the toxicity graph. Okay, this is drug A. And I will take one more example for drug B. This is the efficacy graph and this is the toxicity graph. Sorry, for drug B. Now guys, you have to pause the video and tell me which drug is safe to prescribe. Drug A or drug B? Please come up with your answer. Pause the video and tell me. Yes, obviously drug A is more safe. The meaning is this distance between the efficacy and toxicity is more. Suppose by mistake if I give a higher dose of the drug, patient will not end up with toxicity. So this is called wide therapeutic index. So this is called wide therapeutic index. So if the therapeutic index is more, even if I increase the dose a bit, suppose instead of giving paracetamol 500, if I give 600, nothing will happen. But drug B has narrow therapeutic index. In this drug, if you are going to give 500 milligram, if you give 550 milligram also, patient will end up in hospital with toxicity. So therapeutic index is going to measure a parameter. So they can ask in the exam, therapeutic index is a measure of what? It's a measure of safety. Therapeutic index is a measure of safety. Please write down that. So what are the drugs which have narrow therapeutic index? Examples are digoxin, lithium, and TCS. TCS stands for tricyclic antidepressant. So in the exam, if they tell you a drug has narrow therapeutic index, what do you understand by that? These are less safe to use. Now, if the drug has wide therapeutic index, what do you mean by that? They are more safe to use. That's it. So that is the reason why we understand therapeutic index and why we understand these things. So that is about the quantile dose response curve, and we utilize in determining therapeutic index. So guys, this is what the dose response curve, and this is what you need to understand in this video. So let me repeat. We discussed in this video mainly what is agonist, partial agonist, antagonist, and inverse agonist. We draw the graph for that. Then we understood what is the dose response curve, what is efficacy, what is potency, what is slope of the curve. And we understood that log dose response curve has two types. One is called the graded, which is done in an individual, where if you increase the dose, the response also increases. But in quantile, the response or efficacy is fixed. It's a all or none, whether you see it or not. And we take percentage of population, for example, 100 people, or we express in percentage. So we get two graphs here, efficacy graph and toxicity graph, and that helps us to determine therapeutic index. If the drug has wide therapeutic index, it is more safe. Narrow therapeutic index, it is less safe. And I told you when you prescribe a drug, what is most important is efficacy is most important, or potency is most important. It is the efficacy which is more important when you prescribe the drug. So that is about the dose response curve graph and frequently asked in your exams. Thank you all.